Welcome to the module titled Diabetes Emergencies as part of the Comprehensive Exploration of Diabetes elective at UNC School of Medicine. We will talk about DKA, euglycemic DKA, HHS, and hypoglycemia. DKA is diabetic ketoacidosis. This typically occurs in type 1 diabetes but can also happen in type 2 diabetes. This is life-threatening. The balance between insulin in the fed state and glucagon in the fasting state maintains euglycemia. Another way to put this is insulin is counter-regulatory hormone to glucagon and vice versa. DKA is the imbalance in counter-regulatory hormones, specifically an increase in glucagon, cortisol, and a decrease in insulin, which results in hyperglycemia. So what causes the imbalance and trigger in DKA? There needs to be a relative insulin deficiency or total insulin deficiency. This can occur in type 1 diabetes, new onset, where there is very little insulin being produced. There can also be situations with medication non-adherence where patients aren't taking their insulin for whatever reason. SGLT2 can create an insulin deficit, which causes euglycemic DKA. There can also be situations where there are increased stress hormones. Stress, trauma, surgery, infection, illness all ramp up the counter-regulatory hormones such as glucagon, cortisol, and epinephrine, which will raise your blood sugar. And SGLT2s, as we had mentioned, can also cause this imbalance. The pathophysiology of DKA is laid out here, and I'll walk you through it. There is an insulin deficiency from either insulin non-adherence or new type 1 diabetes, plus an increase in counter-regulatory hormones, so glucagon, cortisol, in the setting of an infection, trauma, stress, and then you combine this with the insulin deficiency in the setting of a SGLT2 or type 1 diabetes or type 2 diabetes. All of these things basically result in an insulin deficit and an increase in the counter-regulatory hormones. So if someone had a surgery and they had an increase in these counter-regulatory hormones and they didn't take their insulin or didn't get enough insulin to meet this surge in counter-regulatory hormones, the insulin deficiency would result in the following things. One would be hyperglycemia, hyperosmolarity from insulin deficiency and the increase in glucagon and cortisol. You get an osmotic diuresis from all this sugar, and then that results in dehydration and potassium loss, and you lose total body potassium, or you lose potassium, resulting in decreased total body potassium. You also get ketosis because you are unable to bring glucose in the cells because of this insulin deficit. And so you can't use glucose, and the ketosis starts because you need a new energy source, and then this ketosis causes metabolic acidosis. The dehydration, potassium loss, ketosis, metabolic acidosis results in symptomatic DKA, which we will discuss on the next slide. So you can see in this picture here, DKA versus HHS. DKA, you have a triad of hyperglycemia, metabolic acidosis, and ketosis. In summary, you have an insulin deficiency plus cortisol, epi, and glucagon increase. You get fatty acid breakdown and ketone production, causing ultimately the metabolic acidosis. So the presentation of DKA and the labs that go along with this condition, the signs and symptoms are hyperglycemia, classic triad of polyphagia, polydipsia, and polyuria. Dehydration, dry mucous membranes, lower urine output. You can have nausea, vomiting, stomach pain. If there's an infection present and causing the DKA, you can have fever, urinary burning, frequency, pain, cough, based on where the infection is. Vital signs will show tachycardia, evident as a result of dehydration. Tachypnic, abnormal breathing. This can be a sign of Kussmaul respirations, which are deep and quick, deep and rapid breathing, deep and labored breathing, that's designed to blow off acid in the setting of ketosis, which is causing this metabolic acidosis. You may also get a fruity odor from the breath, which is caused by the ketones. And then you can also have altered mental status that can be caused by acidosis, metabolic and chemical abnormalities, cerebral edema, dehydration, or a mixture of all of these. For the labs, you'll see a blood sugar greater than 250, pH less than 7.3, a bicarb less than 18, and an elevated anion gap. You'll also see elevated ketone measurements like a beta hydroxybutyrate. You can see low serum sodium, and if you correct this sodium in the setting of hyperglycemia, you may actually have a normal sodium. So it's important to know that you should correct that whenever there's a hyperglycemia. You also need to look at the serum potassium. It can be elevated, but and this elevation is a result of acid and insulin deficiency, causing a potassium shift. But since you've had that diuresis from all the sugar, you're also losing potassium in your urine. So even though it may seem elevated, you can actually have a normal or even a low total body potassium, which is very important when resuscitating a patient. And giving them insulin. So, it's important to keep an eye on this. Um, Serum magnesium is normally low, so you need to watch that or replete as necessary. And then you may also see abnormal UAs or chest x-rays or other scans if there's an infection as well. So now I'll talk about euglycemic DKA and the mechanism behind that. Common causes are SGLT2 inhibitors and pregnancy. And I'll explain it two ways. The first way is basically a carb deficit, and then this carb deficit in SGLT2, basically you have, you're urinating out glucose, and then when you have less glucose and less carbs, you have an overall insulin deficit, and anything causing an increase in the counter-regulatory hormones, um, glucagon, cortisol, epi, such as stress, illness, infection, you'll have this insulin deficit, and that imbalance causes DKA. But you'll have a normal glucose because you've had, you've been in a deficit in terms of carbs. Another way to do it is to look at this chart. You basically have SGLT2 inhibitors, and basically you're getting this glucosuria, and you're losing, glucose in the urine, which is ultimately going to cause euglycemia. You have decrease in insulin because of this relative carb deficit. So you have this relative insulin deficit as well. And then whenever there's any counter-regulatory hormones that increase in the setting of illness or stress, you end up getting decreased insulin and increased counter-regulatory hormones, increased lipolysis. You get the ketosis, and you mix the ketosis with euglycemia, you have a euglycemic DKA. So the presentation of labs of euglycemic DKA can be similar to regular DKA, but you may not have the hyperglycemic symptoms. But you can have nausea, vomiting, anxiety, difficulty breathing, fatigue, stomach pain, and this can be a really confusing presentation because the symptoms don't meet the lab findings. You see a patient that seems like they have DKA, or you may think they have some kind of stomach bug, or they have some kind of you know it can present as like an anxiety. You can see the patient maybe present like they have a flu, or it's just very difficult because you get the labs and it doesn't exactly tell you per se that they are in DKA. But possible infectious symptoms and signs or presence of surgery or other anatomic stressors, small bowel obstruction, um, or nausea, vomiting from sickness, and other things you'll see are the Kussmaul breathing because of still in an acidosis, tachycardia, hypotension, altered mental status, dry mucous membranes, all of the things you'd normally see in DKA. But in the labs, you'll still have an acidosis, which um, you know uh, you may or may not pick up on just based off getting a CMP or something like that, and seeing that, and not really seeing the things you would see in DKA otherwise, such as the hyperglycemic symptoms or the large increase in blood sugar. So you have these symptoms that aren't exactly pointing you towards anything per se, and then you get the labs and you see the blood sugars normal. You're like, this might not be DKA, but then having that story behind it, that they recently had a stressor, and that maybe they're on an SGLT2, or maybe that they're pregnant, would trigger you to kind of look at that CMP and be like, the bicarb is a little bit low, the pH is different, maybe trigger you to look and at least see if there's any signs of ketones, like with the beta hydroxybutyrate, which would be elevated in this situation. Um, You can possibly see changes in lactic acid, and then again the potassium would likely also be low um, in the whole body despite normal or high levels. So low magnesium, low phosphate, possibly low sodium, um, but given normal glycemia, it is less abnormal than whenever you have hyperglycemia. So this whole confusing picture of, oh my gosh, what's going on? Their labs don't really line up. Just having that suspicion with pregnancy, SGLT2s, things like that, to be able to think like maybe this is euglycemic DKA. Here's the treatment algorithm for DKA. It can be confusing, and it can be, certain providers may have certain uh, ways they like to deal with DKA, but it's broken up into a couple different sections here. And the first is fluid resuscitation. These patients are dehydrated, and these patients need fluid. Um, and so first thing to be would be to determine their dehydration status, looking to see if they're severely dehydrated and giving them fluid appropriately to resuscitate them. Um, and then once you determine that, making sure you're hydrating them and keeping them hydrated at a maintenance level as well. And then for potassium, it's really important to remember that whenever you give insulin, it can cause potassium to go inside of cells, and that would cause a total body hypokalemia and could kill someone. So looking to see what the potassium level is. So if it's less than 3.3, you would hold the insulin and replete potassium. If it's 3.3 to 5.2, like I said, the acid base balance that happens in acidosis and the lack of insulin can cause glucose to shift outside, so it may look like you have a normal range, 3.3 to 5.2, but you actually have all of your glucose outside of the cells right now because of the shift, and you actually have a depleted or low whole body potassium. So as soon as you give that insulin, it's going to tank. So you need to replete in that situation too. And then greater than 5.2, you can hold off on the potassium and just continue to monitor it. Because if it's greater than that, it's probably in the normal range. You also want to give insulin to deal with the hyperglycemia, and basically you give that insulin and you stop ketosis and give your body time to clear the ketones. There's some good tools like EndoTool that can help titrate insulin every hour to meet the glucose, and otherwise you would have to do it kind of an old school way where the nurse would or the provider would get a glucose every hour and then titrate the insulin to that glucose. And so you want to make sure that you are lowering the glucose uh, at a certain range so as to not drop it too fast and cause any kind of cerebral edema or any kind of damage from a disrupted metabolic balance, since the fluid kind of will balance itself based on the different particles and molecules within the blood. So just making sure you do that in a safe way, and you're also monitoring pHs, electrolytes, BUN, and things like that. For bicarb, it's a debated topic. Um, you want to see, based on what you're attending, your provider will think. Sometimes people say no bicarb at all. Some people say less than 6.9, you can give some bicarb to help with the acidosis, but that will be provider dependent, and it will take a couple times of going through this DKA algorithm to kind of get an idea of what the next steps are and how you kind of want to manage DKA. So for HHS, hyperosmolar hyperglycemic syndrome, you most often see this in type 2 diabetes, whereas DKA you see in type 1 most often. This is life-threatening. There's a 10 times higher mortality in HHS versus DKA. Typically, the cause is infection in 50 to 60% of cases, and then medications like thiazides, beta blockers, steroids can cause it, and strokes and heart attacks can also cause it. The issue is that you have a high serum osmolarity. There's no acidosis in this condition. As you can see in the picture, the triad is hyperglycemia, high osms, and the absence of a acidosis. Whereas in DKA, you have hyperglycemia, ketosis, and a metabolic acidosis. So the pathophysiology of HHS includes a stressor such as surgery or illness, and then the counter-regulatory hormones will increase cortisol, glucagon, epi, which causes hyperglycemia. In this situation, there's a insulin response by the cells, but it is decreased. There's a relative insulin deficiency, and so this relative insulin deficiency results in a hyperglycemia, and this causes a osmotic diuresis, which basically causes water loss and dehydration. But at the same time, insulin is still being produced because it's most likely in type 2 diabetes where there's still insulin production. And so you don't get the ketosis and subsequent acidemia because the insulin's still bringing glucose into cells and not kicking the body into ketosis. And so you get this situation where you have um, a lot of dehydration and you have a lot of water loss that causes hyperosm, hypertonicity, um, and high blood glucose. So for the presentation and labs of HHS, you'll see infectious symptoms such as fever, weakness, and cough if this is what's causing the HHS. You can see heart attack symptoms, chest pain, shortness of breath, stroke, neurodeficits, altered mental status, signs and symptoms of dehydration and hyperosmosis, dry mucous membranes, decreased urination, delay in cap refill, polydipsia. You can also see altered mental status, which could be the result of many different causes. For labs, you're going to see a significant elevated blood sugar greater than 600, increase in serum osms at greater than 320, but you will not see any ketoacidosis. The treatment for HHS is to treat the underlying cause, most importantly. Again, resuscitation, dehydration, and hyperosms require resuscitation. Electrolyte repletion is similar to DKA. Insulin is a little bit more relaxed than in DKA, and then want to treat the hypertonicity during the treatment with fluids. You can get hypernatremia from all of the fluids that you require. So you might have to give some free water back to help with the hypernatremia. And again, here's the chart for the DKA and HHS treatment. As you can see, the only difference is in the insulin when you give HHS. You may want to go a little bit slower, and you may want to make sure that you kind of keep an eye on it and drop it a little bit slower just because of the hyperosms. So the comparison of DKA and HHS: in DKA, you have ketoacidosis is the main issue, whereas in HHS it's the hyperosmolarity. Type 1 diabetes is most likely in DKA, even though it can be type 2, much more likely in type 1. Type 2 is much more likely for HHS, can be type 1 as well. DKA is typically your younger people, HHS is typically your older people. DKA normally starts in hours to days, whereas HHS is days to weeks. Blood sugar in DKA will be 250 to 500, HHS will be greater than 600. The osms in DKA will be less than 320, whereas they'll be greater than 320 in HHS. There is an anion gap and a decreased bicarb in DKA, but no anion gap in HHS. In DKA, the patient may present as less altered, but they will have Kussmaul breathing and abdominal pain, whereas in HHS, they'll appear a lot more sick, altered. There will be no Kussmaul breathing because there's no acidosis, and likely less abdominal pain. So hypoglycemia is our next topic. This is also an emergency. Glucose less than 70 is considered hypoglycemia, but you typically won't have symptoms until you're less than 55. Patients taking meglitinides, sulfonylureas, or insulin are at higher risk. Typically, type 1 diabetes, people with type 1 diabetes more commonly experience hypoglycemia than type 2, just because of the insulin and uh, the causes. Insulin, basically, if you have your normal dose of insulin, but you don't take in the same number of carbs, this can drop your blood sugar because you have an excess insulin. Illness, alcohol, cortisol deficiency, poor intake, and insulinoma can also cause hypoglycemia. So the presentation of hypoglycemia consists of signs and symptoms that um, symbolize the central nervous system not getting enough glucose. So things like confusion, fatigue, decreased responsiveness. There's also a sympathetic fight or flight response that is trying to warn patients so that they will kind of realize that something's wrong and they will go get food. Um, and another point of the sympathetic response is to increase glucose via the counter-regulatory mechanisms, epi, cortisol, that go along with the sympathetic response. So these patients will have tachycardia, tremors, anxiety, sweating, and that kind of serves as a way to raise the blood sugar, while also warning patients to go find something to eat. You can also have seizures, and if this is not corrected, hypoglycemia can result in death. The treatment for hypoglycemia, in, from a health care provider perspective, consists of identifying these patients early, and this is very important because there is a possibility of death if we do not identify um, blood sugars being low. Um, this specifically can come in handy whenever you have a code and the patient, you're running through all the different things that could be wrong with the patient, and getting a blood sugar to make sure that hypoglycemia is not contributing is always a good move. Also, in the setting of a patient that may be presenting like they're having a stroke to the emergency department or your primary care, they're having decreased responsiveness, confusion, maybe or seem weaker. Um, Getting a blood sugar to make sure that they don't have low blood sugar is a good way to make sure that you're covering all the bases. Um, so if a patient is able to follow commands and swallow, you're going to want to give them something to eat orally or drink, such as foods and drinks high in carbs like soda, juice, crackers, peanut butter, icing. If they're unable to follow commands or swallow, you can use IV dextrose or glucagon. Once they're conscious, though, you need to give them food orally to replenish glycogen and maintain euglycemia, kind of stabilize things. Um, it's important to have a close follow-up with a primary care doctor, endocrinologist, whoever is managing their diabetes to understand why the hypoglycemia happened. This may be a good time for education or education assistance on top of the education they've already received to make sure they understand what happened, why it happened, and how to prevent it from happening again. Um, if the patient is alone, it's important to make sure they understand the rule of 15s. This is basically whenever you have signs or symptoms of low blood sugar, or for whatever reason you check your blood sugar and it's low, and you would see that low number and or have those symptoms, and you would check your sugar, and you would then eat 15 grams of carbs. You would wait 15 minutes, and then you would check your sugar again, and if it's not recovered, then you would eat 15 more grams of carbs. If the blood sugar improves, then you should eat a stabilizing meal with protein and fat that will help restore glycogen and help maintain euglycemia by kind of like stabilizing out your um, blood sugar.